Welcome to PharmaDocs with your host, myself, Dr. Jay Reznick, and Dr. John Roberson. Practicing oral surgeons bring you the latest and greatest in pharmacology as it affects you in your daily dental practice. Okay, good evening. Happy March 24th, Pharma Nation. We're now into spring. Here in LA, it was a spring like 85 degrees. How about where you were, John?
We're around 72, Jay, but the pollen...
That sounds nice and pleasant.
Yes, but the pollen is free-flowing everywhere, okay? Y'all probably don't have to deal with that out there, do you?
Yeah, we do. My patients are complaining. They're all coming in with sniffles and runny noses and scratchy eyes. Yeah, we have that. We have the same issue. It's just hotter.
Yeah, it's sometimes when you have so much pollen, you can't even see the sky, Jay. So,
yeah.
Hey, I need to apologize to the Pharma Nation last week because we were just rocking and rolling, talking about warfarin and the INR, et cetera. Then all of a sudden, I just leave the audience. All right, something happened with our internet, and technology is great when it works, but when it goes down,
luckily it was the end. So I've got some good news for you, John.
Okay.
You remember our old friend Janus Kinase?
Oh, Janus Kinase. That's the stock fund, isn't it?
That's
the index fund that you're investing in, huh?
Yeah, really. It's a signaling molecule in cells, especially in bone marrow, and has to do with allergic and autoimmune reactions.
Yes.
After more than 20 years of research, scientists at Stanford have now worked out the entire structure of Janus Kinase. They know exactly what the molecule looks like. And on top of that, they know how it works now. They've figured out the mechanism of action of Janus Kinase. Remember how we talked about how it's called Janus because that's a two-headed god, and Greek god. And so basically you've got two domains that are sort of similar, and part is inside the cell right here, and then the other part sticks out and is on the outside of the cell. So what happens is when cytokines bind to the Janus Kinase, they bind to both external receptors, bringing it together inside the cell, and that's what activates the Janus Kinase.
Awesome.
Yeah. So they think that a lot of the disorders where you have Janus Kinase reactions going amok, like in leukemias or autoimmune or allergic disease, that like eczema and all those different diseases that Janus Kinase are involved in, that those there's a mutation that brings those two inside portions together, and they're just firing all the time, just as if they were activated without really have been activated.
Well, with you saying that, Jay, you're really going to like our first new drug.
Because
it's sort of semi-kinase related. Mm-hmm. And that new drug is Ztalmy, also known as Ganoxalone.
Yeah.
Right? So you see that oxalone, you think like naloxone or something like that. But this is not. This is a neuroactive steroid.
Right. It's a corticosteroid. In fact.
Right.
There are other forms of this that have been used as corticosteroids for a variety of different diseases, but it's being used for something new that it wasn't previously used for, and that's for the seizures that we see in CDKL5 deficiency.
Yes.
And so for those of you who don't know what CDKL5 deficiency disorder is, it is a CDKL5 disorder is an X-linked disease, and CDKL5 stands for cyclin-dependent kinase-like number 5, and it's a gene on the X chromosome, and it regulates protein MECP2 that is needed for normal brain development. So what happens in patients who have this deficiency is they have abnormal development and growth of their nervous systems. So it basically inhibits the migration, formation, and growth of neurons, and also there's a problem with the chemical transmission of chemical signals between the different neurons and the synapses. And so this affects patients really quite young in the first few months of life.
Yes.
So this drug, they
start having seizures early in life, Jay.
Exactly. So this doesn't necessarily treat the disease, but it treats the seizures, which to this point have been really difficult to control.
Because a lot of times they're usually on a single anticonvulsant monotherapy.
Yeah,
And
or sometimes two.
they'll have to have adjunctive therapy as well too. And so it's really nice to have a breakthrough like this, because since we've started this show, we're starting to see more and more breakthrough, Jay, as far as
a lot of drugs that are for disorders and diseases that there really was no treatment for.
We talked about hemolytic anemia not too long ago, and that now we finally have a drug for that.
Right.
As well as the agglutinin disease as well too. Now we have a drug for that, and now they've discovered the Janus Kinase molecule. So watch what happens there too. I mean, it's just going to be a great ride seeing all of this.
Yeah,
as well.
I think in the next 5 years we're going to see a great increase in what we know about cell signaling and being able to design drugs that specifically modulate certain activities. So the CDKL5 disorder is, as we said, it's X-linked, and so it's about 5 times more common in females, but males it's much more severe.
Okay.
And again, the seizures start in the first 3 to 6 months of life. And so that is a serious disease that we now have some treatment for, at least to reduce the seizure activity. All right. Okay. So what's next?
Wow. We talk about the MABs all the time, the monoclonal antibodies, and here we go again, Opdualag. And how you like the DualLAG, because dual means two.
Two, yeah.
So we've got a combination injection here, and it's used, Jay, now for the treatment of melanoma.
Right. Yeah. And it's actually quite effective. And there are two, as we said, it's a dual drug. There are two components: nivolumab, which has been on the market as Imfinzi for a number of years, and relatimab-rmbw. And it's the relatimab that is the newer drug, and that's actually been shown to demonstrate a clinical effect by blocking the LAG3 lymphocyte activation gene number 3 that is significant for regulating T cells. Now, you would think that something named lymphocyte activation gene number 3 would actually activate lymphocytes, but it does just the opposite. It actually downregulates the response, activation, and growth of lymphocytes, and basically kind of exhausts them in a sense. And so what this drug does, by blocking both the lymphocyte activation gene 3, the LAG3 gene, in addition to the programmed death receptor 1, PD1.
How do you like that name? A programmed death receptor.
Yeah.
I mean,
really,
they're going right after it,
Yeah, exactly. But by blocking those, it kind of brings the lymphocytes back to life.
And Jay, that nivolumab, remember, U-MAB, so the U is coming from a human, all right?
Right.
And then relatimab, the LI means the target is the immune system.
Right.
And you did a great job several months ago when you described this. And now look, almost every show, Jay, we have a monoclonal antibody in there.
Yeah.
Okay. And so
it's been a recurring theme.
It's a recurring thing.
Many of
they're finding more and more
antibodies
patients for this drug. Okay. Yeah. And so, again, these are going to be people that their immune system is suppressed. Okay.
Yeah. And so we got to be careful with them in our offices because they are more prone to infections and complications.
Jay, they're going to come to our office. They're going to need dental treatment. Okay. And so, I mean, many of these drugs that they take, they want to prolong their life.
Right.
All right.
Yeah,
and there's going to be issues with the dentition that we as practitioners are going to have to treat.
Yeah. I see patients on these drugs in my office all the time. I'm guessing you do too.
Absolutely.
Yeah.
Absolutely.
Yeah.
Trying to prolong life, especially in some of these cancers and all that stuff.
Yeah. Melanoma is pretty common. It's as you all know, it's a skin cancer that if it's caught early is very treatable. But once it becomes metastatic, the death rate is very high. In fact, in 2021, there were 106,110 new diagnoses and 7,180 deaths due to melanoma just last year. So this is a
Jay,
significant disease.
A very good acronym with that is called BANS: back, arms, neck, and scalp.
Yeah,
those are
that's where you find it.
That's the 4 common areas for melanoma right there.
Yeah.
So if you see a lesion on your skin or something has changed, a regular size, ulceration or something, get it checked out, please.
Yeah.
All right.
Yeah, I have patients come in weekly that are being treated or were treated for melanoma. And most of them, like I said, if it's caught early, has a very good prognosis, and it can be completely cured.
So to the audience again, Jay, right quick, I just want to run over, the rule number 1, when you see the suffix MAB, M-A-B, we already know what that type of drug is, monoclonal antibody. Rule 2, the 1 or 2 letters preceding MAB tells you the source of the antibody. So what species it comes from.
That's
right. If it's O, MAB, mouse. Zimab, which is chimeric, is part human, part non-human.
And usually mouse.
Right. Zumab is humanized, mostly human, part non-human.
Yeah.
And then UMAB, as I've already said, is human. All right.
Complete of human origin.
And then the 1 or 2 letters before the source tells you where in the body it works. So if we have CI, circulatory system.
Yeah. It tells you the target of the the drug.
If we have KI, it's interleukin. If we have LI, it's the immune system, or if we have TU, it's tumor.
Yeah, T or TU, L or LI if it's immune system. If it affects the nervous system, it's N with possibly an E. And if it's in bone, it's an O with possibly with an S. So O or OS means it targets bone.
And I was going to say too, Jay, you brought up probably 2 shows ago. So like for relatimab-rmbw.
Yeah.
What does the 4 letters as far as that suffix mean? Absolutely nothing. The FDA just came up with another way to differentiate these because we're getting more and more of these onto the market.
Yeah, exactly.
And look, it's a great thing because again, we got more in the armamentarium to fight various types of cancers.
Right. Exactly. Go ahead. I just got to respond to this real quick.
All right. So, and then, like I said, on rule number 4, talking with the MAB. So let's just say we see something like alumtuzumab. So we know it works on tumors, TU, and it's derived from a humanized source, ZU.
Yeah.
Okay.
Yeah. So even if you didn't know exactly what it does, you have a pretty good idea what it does.
So again, the bottom line is when you see these drugs, UMAB, IMAB, they're a monoclonal antibody. You have a patient in your office that's on some type of immunosuppressant. All right. So you'll need to cover them. Okay.
Yeah. Very important point. The next drug is Nasonex 24-hour allergy. And, we're all familiar with Nasacort, which is triamcinolone, and Flonase, which is fluticasone.
Yes.
And I thought that Nasonex, which is mometasone, furoate, monohydrate, was also over the counter already, but it's been prescription until this point, until it was just approved last week, March 17th. So this is coming onto the market as an over-the-counter 24-hour nasal allergy spray. And so it's the first branded prescription to over-the-counter for this company with their Nasonex drug. And so you'll be able to buy it without a prescription coming up real soon.
And people down here where I am, we're going to love that. Okay.
Yeah.
It's going to be wonderful.
Yeah. So it acts as an anti-inflammatory in the respiratory system, and the mometasone is used for all kinds of different disorders of different systems in the body. It can be used for eczema and psoriasis in a cream form or topical form, allergic rhinitis, like in this case for hay fever. Asthmanex is the formulation that's used as an inhaler for treating asthma. And it's usually used for patients who are not responsive to less potent steroids. It's actually more potent than hydrocortisone, but not as potent as dexamethasone.
Okay.
Yeah.
All right. So moving on to drug number 4. Actually, Jay, we just had another drug approved late today.
Yeah.
Called Ztalmy.
Oh,
And
what's that?
that's used.
I guess we'll talk about it more in 2 weeks. But
yeah, it's a transdermal patch for ADHD. And,
oh, really? Okay.
So it's a dextroamphetamine as well
Yeah.
too. But now they have a transdermal patch.
Mm-hmm.
So, but our 4th drug is Adlarity. All right.
Yep.
Donepezil.
Donepezil, yeah. And so what is this drug? How does it work?
Well, it's also now it's a new system it's a transdermal system. Okay.
Mm-hmm.
And it is used strictly for Alzheimer's disease.
Yeah.
And it's a once weekly transdermal formulation, Jay. That's it's an acetylcholinesterase inhibitor.
Right.
And
yeah. So what that does is it increases the amount of acetylcholine in the synapses, especially neuromuscular, but also in the brain.
Right.
And so it basically decreases the effects of Alzheimer's. It doesn't treat the disease, but it reduces the effects by increasing the amount of acetylcholine. Now, the problem with this drug is it interacts with a lot of different drugs. And a lot of different drugs that we may use in dentistry or for anesthesia.
But now, Jay, the pill form of this drug is Aircept.
Mm-hmm. Oh, okay. Yeah. Oh, that's right. Yeah.
Yeah. And so
this is a new delivery system.
Yeah. So we have a new delivery system, and many people are going more toward the transdermal systems. I think it's
definitely more convenient. It's easier to, if it's once a week, then it's a lot easier to remember to take a pill once or twice a day.
Oh,
you get much better compliance. Yeah.
And just like I said, we just got a brand new drug released today. It's going to be transdermal for ADHD as well too.
Yeah. Oh,
but I'm just wondering how many people are going to keep that patch on. All right. I mean, they got ADHD.
I guess if you take a bath or go swimming, you might end up losing it.
That's correct.
But for those patients who don't bathe and don't swim, it's probably a good choice. But so, it's always nice to have these drugs in different forms.
Oh, absolutely. Because I mean, some people may not be able to swallow pills. How many people you know that? And or they may not have an oral solution just yet. And so it's nice to have this transdermal. So you were saying when I interrupted you, you were talking about certain medications shouldn't be taken with these. What are those, Jay?
Well, for one, anesthetic drugs that we use in sedating patients, whether it's morphine, whether it is fentanyl, whether it is diazepam or Versed or propofol, the way those work is by reducing the amount of acetylcholine in the central nervous system synapses. And what this drug does is it increases the amount of acetylcholine in these same areas. So it makes these anesthetic drugs much, much less effective. And so we've got to be aware of that. If we have a patient who's taking this drug,
when you start trying to give more, now you're concerned about when it does start to work, running into some type of respiratory depression issue.
Yeah, well, your margin of error, your safe zone, is going to be significantly less. But
Jay, say that again. Your margin of safety.
My margin of safety is going to be much thinner, much narrower, if you have to give a higher dose of Versed or fentanyl or propofol to sedate a patient when they are on this drug that's an acetylcholinesterase inhibitor.
That's right.
Right, because that drug is counteracting what the anesthetic does.
Right. So now when you start like, gosh, this patient won't go to sleep, and you start giving more and more of this medication, and now you get into ventilatory compromise. Right. Now you've got a life-threatening sedation emergency on your hand right now.
You got to know how to deal with that.
You got to know how to rescue that patient.
Yeah. Right? It doesn't matter if it's an IV medication or if it's oral.
Correct.
It's the same thing.
And anesthesia, as we know, Jay, is a continuum. Mm-hmm. All right. It can go from minimal to moderate to deep to general. And if that happens, you, the practitioner, must know how to rescue that patient.
Yeah. Yeah. So by increasing acetylcholine in the synapses, there are other systemic effects, one of which is affects the vagus nerve, which does a couple things that are adverse reactions or adverse side effects from this drug. For example, increasing the amount of acid secretion in the stomach. So patients who are on this drug, whether it's this transdermal patch or whether it's Aircept, have a much higher incidence of peptic ulcer disease. It also affects the branches to the heart, to the SA node and AV node, increases the vagal tone. And so it can cause bradycardia. It can cause constriction of the coronary arteries. It can cause bronchospasm because it's causing constriction of the bronchi.
Yes.
And so this is not a drug to be taken lightly. It also can affect Parkinson's. In fact, Parkinson's can be exacerbated by the increase in cholinergic activity. It can increase the risk of seizures. If the patient's hyperthyroid, it can increase the effects of that hyperthyroidism on the body. And it can also affect, because it's metabolized by the liver, this drug is metabolized by the liver, that is. It is reduced by about 20% just because of the acetylcholine activity that it creates.
So if we have a patient on donepezil,
Mm-hmm.
automatically we know this increases the chance for GI ulcers and bleeding.
Yeah.
And so here we are trying to do our job.
And cardiac events.
And cardiac events. Here we are doing our job, not trying to prescribe an opioid.
Mm-hmm.
All right. A narcotic. I'm going to write this patient for an NSAID. That is a big no-no.
Yeah, that is too.
Because now I have just increased the chance of a GI bleed.
Right. Mm-hmm.
And you may get a phone call from a family member, hey, the patient that you treated today is now in the ER with a GI bleed.
Right. Yeah, hopefully you either get a call from the pharmacist before they fill it, or in your electronic prescription system, it catches that and gives you a warning. So you got to be sure to read those pop-ups.
Right.
Not just click accept.
Okay. So you'll need to touch base with their physician and say, hey, look, I really don't want to write a narcotic for this patient. I like to write an NSAID. Could you follow the patient with me, or how do you recommend this? Or if they say, yeah, I think we could do a short course of NSAIDs, but with some things we got to tell our patient, should they start getting heartburn or stomach pain, Jay, that just doesn't go away.
Yeah.
All right. So that's a red flag right there.
Yeah.
Or they start having nausea, vomiting, or blood in their vomit, or dark vomit that looks like coffee grounds.
Mm-hmm. Yeah.
That's a red flag.
Yeah.
Okay. Or the same with their bowel movements. If it looks like black tar.
Yeah. Right? Black tarry stool, melanotic stools.
That's correct.
Yeah.
So this is why we have to be concerned about writing NSAIDs,
right?
All right, because you and I have already talked about.
As great as they are, they have a lot of side effects.
We love the drug. Okay, we love NSAIDs, but when you start looking at this vast sea of medications out there, sometimes we can write them, sometimes we can't.
Yeah.
All right.
Yeah, especially when the patients are on lots of other meds. All right, so I guess we want to wrap things up by finishing off our discussion of warfarin and ProTime and INR, and how different medications affect that.
Yeah, because when we were talking about that, and we had a real good section going on, like a 3-part series right there, Jay, because many different medications as well as herbals can interact with warfarin.
Yeah.
All right.
Yeah. The big ones are the ones that start with G, like garlic, ginger, and ginseng. But also fish oil, turmeric, cranberry, chamomile, flaxseed, ginkgo biloba, green tea, dong quai. I'm not sure what that's used for. Feverfew, even magnesium and omega-3 fatty acids. Those all affect the clotting mechanism.
So, and besides
by interfering with it, they all increase bleeding.
That's right. So And then there's systemic diseases, Jay, that influence the INR results as well, like
Yeah.
congestive heart failure.
Right.
All right.
Yeah.
Because it's going to cause hepatic congestion of the blood flow and inhibit the coumadin metabolism.
Exactly. As will
and the issue
some
is
liver
this
disease.
can exacerbate the CHF on that patient. All right.
Yeah. Yep. Yep. And liver disease, you don't get clearance of, or you don't get the production of the clotting factors,
Right.
Because through the vitamin K dependent clotting factors. And so these patients who don't form the clotting factors, they tend to bleed more too with liver disease. And foods can affect it. Especially like broccoli and cauliflower can affect bleeding.
Now, Jay, if you have a single serving, that should be okay. But if people are overdoing it, like eating it multiple times throughout the day and on a regular basis,
or broccoli every night with dinner,
yes,
that's okay. That's okay because it is good for you. But you just have to let your physician know, because they're going to have to modify your warfarin so that, because it's going to make you increase your bleeding, increase your INR. They're probably going to lower your warfarin dose as long as you're consuming broccoli or cauliflower or other vegetables on a regular basis.
And then, okay, Jay, and then another disease is hypothyroidism, because you're going to have a decreased catabolism of the vitamin K clotting factors, which will decrease the INR values. All right. And then conversely, Jay, hyperthyroidism will increase the catabolism.
Right.
Therefore, increased catabolism of the vitamin K clotting factors. Therefore, you're going to have a higher INR level right there.
Yeah. And those are the ones that affect the extrinsic pathway, which are is basically, that's what's measured by the ProTime, or as we mentioned, the INR, the International Normalized Ratio, which is a way to normalize the results and kind of standardize them across different labs.
That's right.
Yeah.
And then of course, other illnesses that could, like, fever, vomiting, diarrhea, these can also affect the INR. But those are the main disease states right there too, as well.
Yeah, that's for sure. So, we're used to warfarin. It's been around for a long time, and we all know that affects the ProTime and INR. But there are a few new anticoagulants the patients are taking that you see marketed on TV all the time, like Pradaxa, which is dabigatran. And this one does not affect the ProTime at all. It affects the thrombin time, which is how long it takes for a clot to form in the test tube. And so if you have a patient on Pradaxa, they can have a totally normal prothrombin time and INR, yet bleed like crazy in surgery. So you have to know that it's a different test for your patient who is taking that blood thinner. Or Xarelto, also, which is rivaroxaban. That drug does affect PT and PTT, but not in a certain proportion. So you can have the patient well anticoagulated with this drug. However, they will still have a normal PT and PTT. So a normal PT and PTT does not eliminate or rule out that this patient has significant clotting inhibition on Xarelto, and same thing with Eliquis, which is another one.
And I'm going to tell you, I'm seeing more and more patients on the Eliquis.
Yeah.
Okay.
Yeah.
Now, unfortunately, one may be better than the other, but you know what drives the market, Jay? It's the insurance company.
Yeah.
All right.
Yeah. Whatever they can get a better deal on, that's what they're going to cover.
That's right. My insurance company's going to cover this, so I got to do that.
Yeah.
And, and I told you that situation where I had a gentleman that was on Eliquis that I've already told you, and you've said the same thing. I don't stop these medications because I'll control the bleeding, but we packed it, sutured it, and everything was doing fine. Left the office CDI, clean, dry, and intact.
Yeah.
All right. But I got a phone call later that evening. Hey, he's oozing some. And what do? I tell him I'll meet him at the office. All right. And I resutured everything. and then told them what to expect throughout the night. When they wake up in the morning, might have a little bit of crusty lips and all that. And therefore their patient doesn't get alarmed over that. And everything was fine after that. But I did put in a phone call to the cardiologist, and he said, just go ahead and stop the Eliquis. We'll be fine.
Yeah.
All right.
Okay.
And so we
you don't want to stop the drugs abruptly.
No.
Without consulting with the cardiologist, because they can get a rebound hypercoagulability.
Correct.
If you stop these drugs all of a sudden. And so you've got to be aware that they're on the drugs for a reason.
Right. And the nice thing about it, he appreciated the phone call as well. And I said, look, if we could stop it now, that would be great. Because I throughout the weekend as well, we could get better control of this. And we did, and everything was perfect.
Yeah. Great.
So that wraps up our INR series as well, too, Jay.
That's it. So we're going to have to think of something else to talk about.
I want to remind everybody that we've got a great program developed just for you called PharmaDent. And it's on www.smarttraining.com. And you just have to go to the menu, find the dental products, and there's PharmaDent right there. And it's for the entire office. 30 hours of CE for everybody in that dental office. The fee is per dental office. You'll not only get pharmacology, you're going to get adverse drug reactions, drug-to-drug reactions, medically compromised patients.
Yeah.
All wrapped up in, it's the universal system, Greg.
Yeah.
Jay.
Yeah.
It's
absolutely.
awesome.
It's absolutely. So we are going to be back. Our next time is going to be on, again, Thursday, April 14th, the second Tuesday of the month. Same time,
Thursday.
Same channel. And
second
close
Thursday.
that out. Second and fourth Thursdays. That's when we're here. So
That's
some
right.
months, so it's twice a month, not every other week, but twice a month on the second and fourth Thursdays of every month.
Shoot us an email if you want another topic talked about, but because we enjoy sharing this with everybody, what's going on, the latest drugs out there, and how it applies to your day-to-day dental practice.
Yeah. Or another thing you can do, which is what somebody sent us a message a couple of weeks ago, is on the comments on our YouTube page or on Facebook. And somebody actually said it would be really nice if you would kind of write down the drugs that you're going to talk about, because we always miss the names. So now in the description, we're including the names of the drugs we're going to be talking about. And so that all came from you. So, if you have questions, if you have comments, we would really love to hear them.
And so in a week and a half now, I'll be lecturing at the Oregon Dental Conference, Jay. So if anybody's listening and is attending my lecture, please come up to the podium after my talk and tell me that you listen to the PharmaDocs. Certainly we appreciate it.
That'd be great. And I'm going to be speaking at the Denver Study Club in 2 weeks from tonight. So if you attend that one, come on up and say hi. All right. Well, good night, John. I guess we've kind of covered everything we want to cover tonight.
We did. And the internet worked great. Awesome.
No crashes this time. So good night, everybody. And
good night, everybody.
We will see you next time.
Bye-bye.
Welcome to Pharma.
All right, now I unmuted. All right. That much better right there. That did good.
Wait. Why is it not? We're still on.
Oh.